Hello everyone, in this video we're going to focus on a very common surgical topic, that is acute intestinal obstruction. Mainly we're going to focus on the pathogenesis and some of the clinical features. Before we go into the topic proper, we need to know different ways in which intestinal obstruction can be classified. A very common classification is acute intestinal obstruction, where there's sudden onset, short duration of symptoms and symptomatology, and one more is a chronic intestinal obstruction, where there's a longer duration of time, either which is causing the pathogenesis or the duration of symptoms is very long. One more method of classification is, this is the most commonly followed, it is classified as mechanical intestinal obstruction, also called a peristaltic intestinal obstruction, or a non-peristaltic, that is a paralytic. This is a very common method of classification because this mainly focuses on the fact that in mechanical obstruction, the peristaltic activity of the intestine is present, it's active. Whereas in this case, the main cause or the culprit behind the cause for this intestinal obstruction is there is no peristalsis present. And this is the reason why the patient may present with symptoms of intestinal obstruction. So this is a very common classification, mechanical and paralytic. Another common presentation or classification is classifying the intestinal obstruction depending on where the site of obstruction is. So it's classified as small bowel obstruction or large bowel obstruction. So when is this classification useful is, based on the symptomatology of the patient, you can classify whether the patient has come with a small bowel obstruction or a large bowel obstruction, and depending on that you can think of the causes that may have caused his or her intestinal obstruction. That is the reason we should know this classification of small bowel or large bowel. So in this video we are going to mainly focus on acute intestinal obstruction and mainly the mechanical. So coming to the mechanical causes of intestinal obstruction, the thing is, to remember the causes of mechanical obstruction, you have to imagine the anatomy of an intestine. So if this is the schematic diagram of the intestine, anything which is inside the lumen, that is present here, will become intraluminal. This is intraluminal. Within the wall of the intestine will become intramural, and anything outside it which is causing obstruction by pressure effect or changing the angulation of the intestine will be classified as extramural. All of them present with very similar clinical symptoms. The only difference will be the management process or the final treatment you do. That is why you should know the different causes for mechanical obstruction. So coming to intraluminal, it can be anything which is present inside the lumen. It can be food bolus which is undigested and it has got stuck there, or it can be bezoars, that is trichobezoar and phytobezoar. Tricho is where there's hair particle and phyto is where there's undigested fiber and plant food particles. Okay, most common ones are the worms, which may cause obstructions, and next are the tumors if present, or if polyps are present, that may present with intraluminal obstruction. Intramural, mainly malignancies and strictures. These are commonly seen in malignancies or strictures and commonly seen in large bowel obstructions because they are more common presentation of large bowel obstruction rather than in small bowel. And extramural, again common entities. The most common cause is adhesions, that is which are caused post-operatively. Then hernial orifices, whenever the hernial sacs contain intestines because of narrowing of the sac at the neck. So if this is the hernial sac and this is the region of the neck of the sac, this is the common region where the hernial sac can go for an obstruction, and the intestinal content which is there inside it in this region will get obstructed and mainly go for strangulation. So these are two common causes for extramural. Other causes, very common cause in children is intussusception, mainly occurs in children but can occur rarely in adults too. We'll focus on intussusception in the next video. So these are some of the common causes for mechanical acute intestinal obstruction. One thing you have to know about adhesions is these adhesions are of two types. Okay, the first ones are called flimsy adhesions and the next ones are called fibrinous adhesions or fibrous adhesions. These flimsy adhesions are very avascular. They are avascular in nature and they are very flimsy and can be easily broken, whereas the fibrous adhesions, they are vascular, very hard, and they are difficult to break. These are formed early in the postoperative period and these are formed very late. Okay, so these two things are seen in adhesions. There's one more thing that comes in mechanical, that is intraluminal, the gallstone ileus. So what is this gallstone ileus is? For example, whenever the person has acute cholecystitis, there's a gallstone impaction, and due to long duration this will get gangrenous part of the wall and the gallstone will drop, and whenever there's inflammation, even the duodenal loop can be adhered to this wall of gallbladder, and due to inflammation going on and on, even this part of duodenal wall which is adherent to the wall of gallbladder will get eroded, and this gallstone here will drop into the small bowel loop. This is called as, and that will cause small bowel obstruction. That is called as gallstone ileus. If this occurs in the young patients, then you can think of a benign disease like cholecystitis causing this. But if this occurs in the old or the elderly, then always keep in mind there's a chance of malignancies, especially the colonic malignancies. Here there's a transverse colon present here and colonic growth present here that will erode gallbladder, causing dropping of the gallstone into the large bowel, and that is causing your gallstone ileus. So if old patient, always think of malignancies because that's a very common cause. So now let's go for pathogenesis of intestinal obstruction. So whenever there is mechanical obstruction in the small bowel, we mainly focus on small bowel, mechanical, there are two things that happen. If the obstruction is present here, then this region will become proximal and this region is distal. Okay, so this is the distal segment and this is the proximal segment. Initially, whenever there is obstruction, the intestines, they try to oppose or overcome this obstruction by increasing the peristaltic activity in the proximal segment. It tries to overcome this obstruction. So that is the reason why the most common complaint in any intestinal obstruction is sudden onset colicky pain. This colicky pain is because of the increased peristaltic action to overcome the intestinal obstruction. So colicky pain. But once this obstruction is not overcome, at that time what happens, this proximal bowel starts to dilate. So instead of this, it becomes like this. Okay, so there is proximal dilatation, and once the proximal part of the bowel dilates, all the secretions which are being secreted by the mucosa, gastric mucosa or the intestinal mucosa or the glands which are present, these secretions will start accumulating. And if these secretions start accumulating, there is no other way for the secretions to go overcome this intestinal obstruction. So the only way is to go proximally. That is the reason why the next symptom is there. That is vomiting. This is more or less seen in case of small bowel obstruction, and that too, the more proximal the obstruction is, more vomiting is a more predominant feature, whereas this is very, very rare in case of large bowel obstruction. This vomiting is because of there's so much secretion stagnating here, they're not going front, and that is the cause for this vomiting. Okay, so once this happens, whenever there's obstruction here, all the secretions, food particles are getting stuck, secretions are getting stuck, and this will be a very good culture media. And as you all know, there are many commensal bacteria present in the in the intestine, and they will grow on these secretions, food particles, and that will increase the growth of bacteria. There will be a bacterial overgrowth, and that will give rise to increased presence of gas, increased production of gas, and that will lead to abdominal distension, bloating, burping. So this may be. So two things you should remember. This colicky pain is present only initially. The intestine proximal segment tries to overcome all the obstruction, and that is why there's colicky pain. But once the intestinal obstruction is not overcome, this peristaltic action stops. So in a patient where there is history of colicky pain and now there is no history of colicky pain, you should never rule out intestinal obstruction. It does not mean that the danger has stopped. It means that the danger is still present, and you have to evaluate very properly and act very quickly, because stoppage of peristaltic action is mainly a defense mechanism. It is to prevent the vascular insufficiency occurring at this part of the junction. If the intestinal secretions peristalsis continue against obstruction, there will be vascular insufficiency. So to prevent this, the intestinal activity or the peristaltic activity stops. Okay, so these are two things which occur. One more thing, important thing is you have to differentiate between small bowel obstruction and large bowel obstruction, mainly based on the clinical features. Small bowel obstruction, vomiting is a very predominant symptom. Always remember, more proximal is the obstruction, vomiting is a more earlier symptom. More distal is the obstruction, vomiting is very, very late. Whereas large and more distal is the obstruction, abdomen distension occurs very fast rather than vomiting. And constipation occurs very fast in case of distal obstruction. This constipation can be absolute, that's total constipation, that's called obstipation, where the patient is cannot even pass flatus, let alone feces, or there is relative where the patient is able to pass flatus but not feces. One thing you should remember is, initially when there is obstruction, even if it's small bowel, the distal part is still undergoing peristaltic movement, which is normal. And this empties all the flatus and the feces. So if patient does not have constipation, does not mean that there is no obstruction. Other symptoms and signs need to be taken into account. So these are a few things which needed to be said in this video on intestinal obstruction. Hope it was made useful. At least some things got covered. Thank you for watching. Subscribe and comment below. Thank you.